Should we get started soon? Okay, welcome to the next session, Novel Radiobiological Advances in Head and Neck Cancers. My name is David Yu. I'm a professor of radiation oncology at Emory University School of Medicine. This is our Emory Woodship Midtown Hospital in southeast Midtown Atlanta. This is the tallest building in the southeast, the Bank of America building. If you haven't been to Atlanta, we're home to the 1996 Olympics, Coca-Cola, as well as the world's busiest airport. All right, I work at Emory University School of Medicine. I receive funding from NIH as well as Department of Defense. So head and neck cancers are the 6th most common cancer worldwide, with 870,000 new cases and 440,000 deaths in 2020, according to ACS GlobalCan. 90% of these are head and neck squamous cell carcinomas. If we look on the American Cancer Society Facts and Figures page for 2025, estimated new cancer cases is about 60,000 in 2025. About 40,000 of these are male, 20,000 female, and about 13,000 deaths. Interestingly, Taiwan has one of the highest incidences of head and neck cancers in the world, 27.6 versus 9.19 of 100,000 US in 2023. If we look at outcomes have improved over the years. So in 1970s, survival rates about 50 percentile, 90s, 60 percentile, and in 2000, 2020, about 70 percentile. Unfortunately, Taiwan also has one of the highest mortalities from head and neck cancers in the world, 8.86 to 3.34 out of 100,000. So what are the causes of head and neck cancers? Tobacco, alcohol, and increasingly human papillomavirus, HPV. So HPV causes about 60-70% of oropharyngeal cancers in the Western world. In Taiwan, it's actually rising, about 30% in 2022, and likely even higher today. And we know that HPV is associated with better outcomes. So this is the NRG 0129 study, kind of comparing HPV positive versus negative cancers, much better outcomes with HPV positive cancers. And then a most recent NRG HN005 study, 2-year progression-free survival of 98.1% in the standard of care arm in HPV positive, locally advanced head and neck cancers. So what is the time limit therapies for head and neck cancers? So early 1900s, both surgery and radiation therapy were treatment modalities. And in fact, 75% of head and neck cancers are treated with radiation therapy, indicating significance of this treatment modality for head and neck cancers. Cisplatin RT remains standard of care for most locally advanced head and neck cancers. So in 2006, Erbitux or cetuximab was approved for treatment of locally advanced head and neck cancers. In 2016 and 17, Pembro and nivolumab were approved by the FDA. And immune checkpoint inhibition has emerged as a promising therapeutic approach for many of these cancer patients. And then we have other treatment modalities right now, such as the FDG mycinidazole that Nancy Lee has been spearheading, as well as now kind of the genomic age with whole exome sequencing. So what is the rationale for cetuximab? So EGFR is overexpressed in 80 to 90% of head and neck cancers. Cetuximab or Erbitux is a chimeric monoclonal antibody. So it targets this EGFR receptor and in such a way blocks binding of natural ligands such as EGF as well as TGF-alpha, and thus disrupts signaling. So when you don't have signaling, you have impairment of proliferation, metastasis, survival, angiogenesis, and growth. Now, the single agent response rate of cetuximab is very low, 11%, but it synergizes with many other therapies, including radiation therapy. Other mechanisms for cetuximab including blocking EGFR by endocytosis, as well as mediating antibody-dependent cell-mediated cytotoxicity. So this is the Bonner study in 2006, seminal study comparing cetuximab RT versus RT in locally advanced head and neck cancers. And there's an improvement in both local regional control as well as overall survival. And this led to the approval of cetuximab for this setting. So what about in the adjuvant setting? So this is a recent study just published this year in 2025 by MACTE. Energy 0920 comparing post-op cetuximab RT versus post-op RT alone in intermediate risk resected head and neck cancers. So intermediate risk is defined as no positive margins, no ECE, close margins less than 5 millimeters, PT3 to T4A or PN2, or T2 oral cancers with depth invasion greater than 5 millimeters, or positive peritoneal invasion or LVSI. So the post-op cetuximab RT arm associated with improvement in disease-free survival, but not overall survival. And this improvement in survival, disease-free survival rather, was only seen in the HPV negative arm. So if you look at the HPV positive, you have like 10-year disease-free survival, even out to 10 years, like 90% plus. It's very hard to kind of improve upon that. So can you add cetuximab to standard of care cisplatin RT? Energy 0522 addressed this question and utilize cisplatin concurrent accelerated RT plus or minus cetuximab in locally advanced head and neck cancers, and effectively no difference in progression-free survival, overall survival, local control, or distant metastasis. Now, what about in the HPV positive setting? So Energy 1016 de-escalate compares cetuximab RT versus cisplatin RT in HPV positive oropharyngeal cancers. And in both cases, we had kind of impairment in outcomes. So the non-inferiority studies were both negative, and so standard care still remains cisplatin RT. So indications for cetuximab RT in definitive setting include locally advanced head and neck cancers ineligible for cisplatin, but consider in intermediate risk head and neck cancers in the adjuvant setting. So it's well known that radiation works by damaging DNA and activating the immune system. So radiation induces multiple types of DNA damages, double-strand breaks being most deleterious. And the DNA damage response recognizes that damage and coordinates diverse DNA repair and checkpoint pathways. But DNA damage, or radiation rather, also induces activation of the immune system. So damages cancer cells, releases tumor antigens, activates dendritic cells, as well as primes these effector T cells. So, and we know the tumor microenvironment responds to both radiation as well as immune checkpoint blockade. It's an example of immune checkpoint blockade here with pembrolizumab blocking kind of that PD-1, and you block the break, so thus the T cell can then attack the tumor. But radiation also induces tumor antigens, activation of a set of T cells, recruitment of tumor-associated macrophages, as well as regulatory T cells. So what are the current immunotherapy indications in head and neck cancers? Largely in the recurrent metastatic setting. So in 2016 and 17, pembrolizumab and nivolumab were approved in recurrent platinum refractory recurrent metastatic head and neck cancers based on Keynote 012 and Checkmate 141. In 2019, pembrolizumab was approved as a single agent for PD-1+, so combined positive score greater than 1, and in combination with platinum and 5-FU for first-line treatment of recurrent metastatic head and neck cancers. This is based on Keynote 048. And then in 2023, toripalimab was approved in combination with gemcitabine and cisplatin for first-line treatment of recurrent metastatic nasopharyngeal cancers. So what about in a definitive setting? Most of these studies are negative. There are two recent studies have had reports of potential benefits. Perioperative pembrolizumab for locally advanced head and neck cancers based on Keynote 689, and post-op nivolumab with cis-RT and resected high-risk head and neck cancers based on GORTEC 201801. So this is a Checkmate 141 study. Compare nivolumab versus chemotherapy and recurrent metastatic head and neck cancers, and basically showed improvement in both overall survival as well as progression-free survival in the nivolumab arm, and led to approval for nivolumab in head and neck cancers. The Keynote 040 study compared pembrolizumab versus chemotherapy and recurrent metastatic head and neck cancers, and also showed an improvement in overall survival leading approval of Pembro in this setting. So what about based on PD-L1 expression? So Keynote 040 had subgroup analyses, and if PD-L1 combined positive score was greater than 1, there's an improvement in outcome. If the PD-L1 combined positive score was less than 1, then no improvement in outcome. And combined positive score was defined as number of PD-L1 positive cells, tumor cells, lymphocytes, macrophages, divided by total number of tumor cells times 100. So Keynote 048 compared Pembro versus cetuximab chemo and recurrent metastatic head and neck cancers, showed both improvements in overall survival with CPS greater than 20 or greater than 1. So there's another arm to this study, Pembro and chemo versus cetuximab and chemo and recurrent metastatic head and neck cancers, and it also showed improvements in outcome with CPS greater than 20 or CPS greater than 1. But however, there are subgroup analyses, and this showed that if CPS was less than 1, then there was actually, in fact, a trend toward decreased survival with the Pembro alone arm, and really no significant difference in outcome with Pembro and chemotherapy versus cetuximab chemotherapy. So Jupiter-02 study studied toripalimab plus gem-cis versus gem-cis in recurrent metastatic nasopharyngeal cancers and showed improvement in progression-free survival and overall survival with the toripalimab and chemotherapy arms. Based on PD-L1 expression, there was improvements with PD-L1 high as well as PD-L1 low. What about based on EBVA DNA copy number, which has been associated with prediction for outcomes as well as a prognostic factor in nasopharyngeal cancers? Whether it was high or low, there was improvements in outcome. And if you look at kind of like some of the data here, there was in the toripalimab arm a significant decrease to undetectable levels and a reduced rate of increase, as well as a reduced time to increase. So can radiation stimulate potentially kind of immune checkpoint response in metastatic head and neck cancers and kind of inducing an abscopal response, so outside kind of the tumor response? So a study led by Nancy Leek and colleagues, nivolumab plus SBRT 9 grade times 3 versus nivolumab in metastatic head and neck cancers, and really no difference in overall response rate and no difference in abscopal effect or overall survival rates, unfortunately. So what is the role of immunotherapy in kind of definitive setting in head and neck cancers? Unfortunately, most of these studies are negative. So just as Javelin 100 study led by Dr. Lee, avelumab anti-PD-L1 inhibitor plus chemo-RT versus chemo-RT in locally advanced head and neck cancers, key eligible criteria, locally advanced head and neck cancers, HPV positive or negative, randomized to avelumab versus avelumab plus standard care chemo-RT, followed by kind of maintenance avelumab versus standard of care chemo-RT. And, really just no difference in progression-free survival or overall survival. Now, they did do kind of an exploratory subgroup analysis, and there was a trend towards improved progression-free survival with PD-L1 greater than 25%. The GORTEC REACH study compared avelumab, cetuximab RT versus cis-RT or cetuximab RT. So if they were fit for cis-RT, then randomized cetuximab with RT plus avelumab versus cis-RT. And if not fit, then cetuximab with RT plus avelumab versus cetuximab with RT. And essentially, like in both arms, really no difference in progression-free survival or overall survival. The Keynote 412 study compared Pembro chemo-RT versus chemo-RT in locally advanced head and neck cancers. So just basically kind of this randomization, Pembro chemo-RT versus standard chemo-RT. And also no difference in outcomes here. There was a trend toward improved event-free survival, but this did not reach the significant threshold of less than 0.024. the INVOKE-010 study, adalimumab anti-PD-L1 after definitive therapy in locally advanced head and neck cancers. These patients had locally advanced head and neck cancers and could receive either surgery or definitive chemo-RT, and then randomized afterward to adalimumab or placebo. And basically no difference in event-free survival or overall survival. This is just published this year in JAMA. So what about an HPV positive setting, HN004, compared development RT versus cetuximab RT in head and neck cancers with contraindication to cisplatin, and really no difference in significant difference in outcomes. So why is it that these patients have not done well? Perhaps taking analogy from our lung cancer patients, Pacific 1 study where durvalumab was added after chemo-RT, we showed an improvement in progression-free survival and overall survival. On the other hand, in Pacific 2, where durvalumab was added concurrently with chemo-RT, there was no difference in outcomes. So perhaps it might be just a sequencing issue, or perhaps it may be the tumor draining lymph nodes. So there's a number of studies now published, Sudawi, Dara, and a number of other studies, where if you ablate the ipsilateral tumor draining lymph node, so if on the ipsilateral side, then you ablate you eliminate the immune checkpoint inhibitor response. So on the ipsilateral side, the tumor continues to grow, in contrast to contralateral side. And this worsens overall survival, impairs conventional type 1 dendritic cell and type 1 interferon signaling, which are both necessary for immune checkpoint inhibitor responses and lost with lymphoablation. So two potentially promising studies, Keynote 689, studied basically neoadjuvant and adjuvant pembro, so kind of perioperative. Pembro surgery, then received pembro with RT cisplatin, or if low risk, then pembro with RT, or to the kind of standard of care arms. And this showed, reported in they have a report that there's a significant improvement in event-free survival and major pathological response and trend toward improved overall survival in pembro arm. And it's been reviewed by the FDA and should have a finding by June of 2025. The Nivo post-op GORTEC 2081-01 study, post-op Nivo and cis-RT versus post-op cis-RT and resected locally advanced head and neck cancers. And in this study also reported a statistically significant improvement in disease-free survival and the nivolumab arm. So we're just awaiting those results. So this is kind of the immunotherapy cycle where, we have release of tumor antigens that can be induced by radiation or antibody drug conjugates or target agents or oncolytic viruses. This then presents to dendritic cells, cancer antigens, can potentiate by tumor vaccines. You need to prime the T cells. You can potentiate by immune checkpoint inhibitors or cytokines. And you also need kind of infiltration of T cells into the blood vessels as well as tumor stroma, which you potentially potentiate with VEGF inhibitors or tyrosine kinase inhibitors. And you can potentially also use kind of like CAR T cell therapy, specialized or personalized to each patient as kind of a direct approach for cancer therapy. So multiple combination therapies are being investigated, and it's just 3 of them. I mean, I just chose 3 out of like many other studies. A number of kind of these dual targeted therapies now, anti-EGFR and anti-LG25, petosemtamab is being investigated with pembrolizumab, Fortify HN01, Vicarious FUS alpha, anti-EGF as well as TGF beta, and also cabozantinib, which is a tyrosine kinase inhibitor with pembrolizumab. So, there's a rationale for potentially harnessing immune system in kind of local recurrent setting. And, rationale is that cure is still potentially possible with this population. So, what are the best combination approaches? in local recurrence? Could it be surgery or re-radiation? Can you combine this with immune checkpoint inhibitors? What is kind of the right sequence, and what are the right agents? And are there potential biomarkers that might potentially predict response to this therapy? So a number of years ago, the National Cancer Institute in the U.S. Established a radiation oncology biology integration network. And I direct one of those centers along with Tim Chan at the Cleveland Clinic. And the rationale of these Robin centers is kind of these deep multidimensional characterization trials where we're collecting patient samples before, during, and after radiation treatment and doing various deep omic approaches, RNA-seq, deep exon sequencing, immune profiling, single-cell RNA-seq, and collecting a lot of data, determining mechanisms for resistance. Each patient, because we're collecting longitudinal data, has kind of their internal control, and there's also kind of an important workforce cross-training core development to this. So the structure of the Robin Centers is this tripartite clinical radiation oncology, medical physics, and radiation biology. There's promotion of kind of synergistic interdisciplinary team science. And these are the centers now that have been approved. We were one of the 3 original centers, all kind of like different disease sites, initially all kind of multi-institutional. And 2 years ago, additional 2 centers were also awarded. And so this is our GenRed Center, Genomic Microenvironment Determinants, Temporal Dynamics, and Efficacy of Radiation-Based Combination Therapies, led by Tim Chan, myself, and Jake Scott at Cleveland Clinic. Our cross-training core led by Xiaofeng Yang at Emory and Omar Mian, who's now at University of Washington. And then we have 2 molecular characterization trials, one bladder cancer trial with adaptive radiation therapy with concurrent sacituzumab govitecan, which is an antibody drug conjugate with SN38 and irinotecan metabolite conjugated to anti-TROP2 that's expressed in many cancer cells. And this is done in muscle-invasive bladder cancer. And then we had also a re-radiation study in head and neck cancer with nivolumab. And we had a transitional clinical correlates core, and then 3 different research projects. One, genetic immune mechanisms underlying radiation with SG and bladder cancer. One, transcriptomic dynamics and temporal reprogramming during radiation treatment. And a 3rd project that I co-led, molecular mechanisms underlying response to radiation and immune checkpoint blockade in head and neck cancers. So this is our structure of our MCTA trial in bladder cancers, key eligibility criteria, muscle-invasive bladder cancer, T2 to T4A. Patients all obtained a maximum TURBT and then had concurrent adaptive RT with SG or standard care with cisplatin. And, we're collecting samples before, during, and after RT treatment, collecting urine cytology, getting MRI before, during, and after course of treatment, and doing various correlative studies. Our MCTB head and neck re-radiation study, key eligibility, recurrent and secondary head and neck cancers, overlap with prior field of greater than 40 gray, and RPA class 1 or 2. All patients received, or rather the Nivo arm received preoperative pre-RT Nivo, followed by Nivo with concurrent RT, or if they obtained standard care cis RT, and then followed by maintenance Nivo. And throughout this, we obtained tissue before, during, and after radiation treatment. We collected saliva as well as serum, circulating tumor DNA, and doing various kind of omic approaches. And so we had a transitional clinical trials correlates core where we're doing comprehensive kind of immunophenotyping, hyperparameter flow cytometry, single cell transcriptomics, spatial transcriptomics, and various genomics. So our phase 2 study of IMRT re-radiation plus concurrent adjuvant nivolumab has now been published, published in JAMA Oncology in 2024. And we found an estimated 1-year and 2-year progression-free survival of 61.7% and 43.2%. So this compares very favorably to historic controls. rejecting the null hypothesis of 1 year progression-free survival less than 43.8%. And we've done some kind of initial correlative studies here. This is looking at peripheral blood CD4 plus T cells, where we see this kind of increase from baseline to week 2 to 4. And this is associated with a trend toward worsening progression-free survival. And these T cells are kind of like more an inhibitory cell, so perhaps not that surprising. Also looked at CD8 plus T cells and found a trend toward improved outcomes with increased CD8 plus T cells. Looked at FOXP3 regular T cells here, and with a higher percentage or a number of FOXP3 regular T cells is associated with worse outcome, which also perhaps may not be surprising that they're kind of more inhibitory toward the anti-tumor immune response. So our project 3 is to kind of investigate mechanisms for resistance to radiation and immune checkpoint blockade versus radiation and cisplatin. This is work by one of our members of our team, Rafi Ahmed, where he did single-cell RNA-seq with HPV-positive tumors, so head and neck cancers, and found these various different clusters of CD8 plus T cells. You have these kind of stem-like CD8 plus T cells, a transitory cluster, and this kind of terminally differentiated cluster. And moreover, we have found these kind of immune niches consisting of these antigen-presenting cells, in very close proximity to these stem-like CD8 plus T cells. And these niches seem to play a role in maintaining and differentiating these stem-like CD8 plus T cells. We also have some data showing that when you have kind of higher niche proportion, this is associated with better outcomes. So this is work by Zach Buchwald on our team, where you're combining RT and anti-PD-1 therapy, and this helps us synergize to promote progenitor stem cell tumor infiltration, and you have impaired tumor growth. And there's a whole body of data showing that when you have dysregulation of DNA damage response genes, this leads to alterations in various immune populations. So for instance, here, dysregulation of BRCA1 and BRCA2, we have alterations in this stem cell population. Additional work that we recently published showing that radiation and immune checkpoint inhibition can increase stem-like CD plus T cells in tumor infiltration, but this also depends on the tumor-draining lymph nodes. So if we use this drug, FTY-720, and it prevents egress of T cells from the tumor-draining lymph nodes, then you have kind of impairment in immune infiltration of these stem-like CD plus T cells, and you have increased tumor growth. We've done some kind of initial analyses on our head and neck samples we've collected here, looking at kind of different immune populations here. And you can see in the well-infiltrated cells, we have increased immune niche proportions compared to those that are more poorly infiltrated. And we've also done kind of flow cytometry looking at various immune populations where we collected these serum samples, throughout the course of treatment, analyzing for potential response to RT treatment and immune checkpoint blockade, as well as kind of potential resistance mechanisms that might develop. And so, this is kind of very preliminary right now, but you can see kind of like CD8 plus T cells showing, some increase there. So this is still ongoing work that we're still performing, both on our RT and immune checkpoint blockade arms, as well as also with the standard care RT and cisplatin arms. So, some future directions and questions, what are the best biomarkers for resistance to immune checkpoint inhibition in RT? Could it be, potentially PD-L1, which we've shown does have some predictive and prognostic significance in at least some studies, or could potentially be, various other biomarkers that we're investigating in our studies. Should we avoid radiating the tumor-draining lymph node, which some of our data suggest, at least in preclinical models? what is the kind of optimal sequencing for incorporation of immune checkpoint blockade with RT? Should we do this concurrently, potentially doing it kind of at neoadjuvant or even adjuvant setting? What about optimal dose or fractionation? And potentially can we combine other targeted agents to combine with immune checkpoint inhibition and RT? So that is all I have, and happy to take any questions. So thank you for your attention. Yeah, I mean, you don't necessarily need it. Oh, yes. Yeah.
I would like to ask what's your recommendation with irradiation dose? Because for radiation, we are here about the carotid bowel syndrome, so the dose may not go too high. So what's your recommendation? Also, when combined with IO, can we lower the irradiation dose?
Yeah, I mean, right now, we're still doing kind of like for definitive therapy, right? Like somebody gray. I think right now there isn't very good data on kind of reducing that dose. I mean, if you look at like, HN 005 that Su Yam just presented at Astro last year, 60 gray versus with I think it was Pembro as one of the immune checkpoint inhibitors, certainly like worse outcome than doing 70 gray with cis. So, I think right now there isn't sufficient data to dose de-escalate. All right, well, it's really late, so so thank you so much for your attention and staying this long.